2, 1. Hello, I'm Domingo Garcia, National President of LULAC, and we're here to get information to all the residents of North Texas as to what's going on. What we've seen in the initial numbers is Latinos are disproportionately being impacted by COVID-19. We've seen many factories here in Dallas, a sausage plant where several Latinos have died already, many testing positive. We've seen a fruit processing plant, the Metroplex, also many people getting sick, nursing home, prison, and it appears that the majority of the positive tests on COVID-19 have been Latinos. So with us, we have Dr. Roberto de la Cruz at Parkland Hospital, and he will talk to us a little bit about what we can do to protect our families, to protect ourselves. I get a lot of calls. Domingo, they wanted me to go to work. I don't feel safe. They're not getting the protection that I need. Is it okay? Do I have to go to work? And what are my risks? So Dr. de la Cruz, can you give us an update as to what you're seeing and what the community can do to protect themselves?
Thank you. I appreciate the time to be able to be with you today. I am Roberto de la Cruz. I'm Parkland's Chief Clinical Officer. And on behalf of our patients and our staff, I really appreciate the time and the opportunity to give you an update about COVID-19. What I will do today is give you a little bit of grounding information and background on disasters. I'll give you Parkland's current status as of today in terms of the patients that we have, the number of patients that we have tested. I'll tell you a little bit about what we have learned from other hospitals and what you have seen in the media and how we've been trying to mitigate those issues. An update on COVID testing results, some basic recommendations for individuals and communities, and then we'll have some time for questions. This is a graphic that shows you the National Disaster Recovery Net Framework. This applies to any type of natural disaster. What we have right now is something very atypical because usually we have a disaster that is self-limited. It is either an incident, a hurricane, a mass casualty incident, and then the communities usually recover very quickly. This applies also to the COVID issue. And it tells you that communities will eventually recover on their own if there's a natural disaster. They eventually on their own recover. However, the goal of the Natural Disaster Recovery Framework is for communities to be active, prepared, and prepare pre-disaster so that way they optimize the time that they're down and the times in which they're still sort of in the recovery period. So for example, the National Disaster Recovery Framework is trying to help communities be in the blue line so that way after an incident, you can help the community recover faster. This diagram applies to your organization. It applies to Parkland as an organization. It could apply to Dallas County, but it can apply also to your family. Did you prepare before COVID? Did you have enough information about it? Were you ready for the things that were going to happen? And then now, how are you helping your family and your community recover after the disaster? And it is really important to see that recovery is a continuum and it is not very fast. It is not uncommon after a hurricane that you revisit that same hurricane site a year later and you still that the communities are still in recovery mode. However, the aim of this framework is to make that quite quicker. I'm going to give you a little bit of an information here that I think it's pretty relevant. And so this is the why, and this will give you, the blue lines give you the average causes of death in Dallas County over a 60-day period. And so we're overlaying with the number of deaths from COVID. And then in healthcare, we can see why we were really anxious about this, because you see that COVID deaths quickly start becoming higher than other causes of death. And in a 60-day period, you will see what happens. So it's pretty impressive that by day 60, COVID-19 is the third leading cause of death in Dallas County, behind number 1, which is diseases of the heart disease and stroke, and malignant neoplasms cancer. So that is the nature of the medical reality right now that we're seeing. So moving on, to give you information right now about Dallas County. So we have had, as of yesterday, almost 9,000 confirmed cases and 211 deceased people with COVID. Parkland confirmed the first local transmission from COVID in Dallas County. That was in March. And we identified a person who had not traveled to one of the hotspots internationally. And we had a high suspicion due to the way that he presented clinically. And we confirmed that that person had actually been in contact with another person here in Dallas. Parkland has completed 8,154 tests. Out of those, 1,272 have been positive. We have admitted to the hospital 438 patients. Most of them, as you can tell, have been discharged to recovery, and we have 59 active patients right now in the hospital. This actually is mimicked by other hospital systems in the area. We are probably the largest single site in terms of testing in all of North Texas. However, other hospital systems also have had active patients admitted to the hospital in these numbers. This is the volume of cases that we have had. The total number is the purple graph, and the patients on a ventilator has been, you can see the gray graph. We activated our command center on February 27th. We had our first meeting about COVID in January 27th. And you can see how we were trying very hard to do that pre-disaster preparation because we could predict that we were going to have, patients coming in. What you see now is effective mitigation strategies. So you see that we did not have an overwhelming number of patients at any number of time in the hospital. If we would have had those 300 or 400 patients at one time in the hospital, it would have been really difficult for the healthcare system to actually take care of them and recover. So we have seen sort of a plateau in number of patients. You can see that the highest number was nearing 80, and then right now we're in the 50 range. So it looks like, and we're hoping for a little bit of a slow improvement, but we're preparing to have like a kind of like a lower plateau, and it looks like it's going to be very difficult for us to reach zero again. This is a graph of the zip codes in Dallas County and the number of COVID patients that have been reported in those areas. This is public information, and you can access it through the Dallas County website, Dallas County Health Department website, and they actually have an interactive map that you can actually zoom into a zip code, and it gives you the number of cases that have been reported. And you can see that there have been cases of COVID reported everywhere in every zip code, except one which probably doesn't have a lot of housing. The hotspots that you see, the areas in red and in orange, represent areas of concentrated nursing homes. One of them is our county jail. The other one includes that meat packing plant. And those are the areas that have been really highly impacted. But COVID, you can tell, has been seen in every zip code in Dallas County. This is to tell you what we have learned from other hospitals. We learned from other hospitals that were in the front line of COVID that there were going to be limitations in testing. And so hospitals need rapid testing. When a patient comes in, you'd like to quickly diagnose them and decide what treatment team and what location of the hospital they would have. And initially, the tests that were available were all send-out tests. You would have to mail them out, and it would take 3 to 4 days to get a result. That was the reality. And we were really fortunate that because of this, we started having redundant testing to try to account for some limitations. Other hospitals were starting to do multiple strategies for testing. We learned about the drive-through testing from other areas. We were the first ones in Dallas County to institute a drive-through testing. We knew about the risks in nursing homes, so we have been testing nursing homes. And we knew about the risk in locations like the county jail, and so we developed some strategies to mitigate that risk. We were told about challenges in suppliers. If every hospital in the country all of a sudden needs to have the same protective equipment, then it becomes very scarce. We learned about conservation strategies for masks and gowns, and about putting patients cohorted in a location to prevent employees from having to change from their gowns constantly and use all their supplies. We also learned how to extend some material. So instead of changing one mask per patient, we can give you that mask for the whole day if you're taking care of all COVID patients. And we also had to limit some procedures and some surgeries which require the use of gowns and masks so that we could conserve them.
Dr. De La Cruz, we've had some questions from employees that some employers are doing the antibodies blood test, where they basically prick your finger and do a test that looks like a pregnancy test, and then the COVID-19 nasal test. Can you tell us the difference and what are the I guess, which one is the more accurate in terms of not having false positive or false negatives?
Yeah. The only way that you can diagnose an active case of COVID is through the nasal swab, through the PCR. And you can diagnose it an active COVID case if the patient is shedding, virus through their nose. So that means that they have been either symptomatic or they're about to be symptomatic. So for example, if I have a nasal swab that is negative today, that doesn't have me free and clear, and that I don't need to, protect myself and do social distancing, because that means I can catch it, next week, tomorrow, or the next day. So the nasal swab is the only test that can actively diagnose COVID. The blood test can tell you if you have developed antibodies to COVID, meaning if you have been exposed and perhaps recovered from COVID. The issue with that test is that the science is still not 100% clear. So if you have if you have antibodies for COVID, it is unclear if those antibodies are protective. And so, for example, we would not recommend that somebody who has positive antibody, they'll change the way that they protect themselves, because the science has not gotten very close to that. This virus is the same family as the common cold. And conceivably, if you have a common cold virus today, you will develop immunity towards that specific virus. But a few years from now, if exposed again to it, you can catch it again. And so with COVID, we don't know 100% if that immunity is protective or how much immunity is really protective. Those tests just started coming online about 2 weeks ago, the antibody tests. And I think they're helpful, but I think they're not helpful for an employer and they're not recommended for an employer to test people, and if they're positive, put them together to work, all working together without equipment, without protection. Nobody's advocating for that right now.
Okay.
So we have the availability for testing has improved. At Parkland, I said earlier, we have completed many tests. Our patients have access to testing through a telephone appointment, and then we can have them come to our drive-through sites. And if they don't have a car, we have open testing in all of our community clinics by previous appointment. We do it that way because we don't want somebody walking in without knowledge of the clinic that they're coming for a test. And we have a different entry point for those patients. That way we protect the other staff that's in the clinic and the other patients that are in the clinic. And then Parkland is supporting general population testing. We are the ones that are doing all the swabs at the American Airlines Center and also at Ellis Field, and those will continue through the end of June. So the question about disparities is really important. So this is the question about disparity. These are our patients, and so these are our positive patients. We have had 66% of our patients are Hispanic. Parkland has about, we mirror Dallas County, 45 to 50% of our patients are Hispanic. So you could say, well, we have more Hispanic patients that are positive, but also you could argue that we are in the community testing our patients and encouraging our patients to test. So you could say this is because either our community is sicker or because our community has more access to tests. So that question has a very difficult answer, especially when you overlay this slide. So this is the population of Dallas County. You can see that it is true that most of the confirmed cases have been in Hispanic, people in Dallas County. However, the number of hospitalized patients is not as high as the number of people diagnosed, and definitely the number of deaths has not been as high as the number of people diagnosed. Our community tends to be a little younger in Dallas County, and then the mortality rate is higher with age. And then you see that a reverse disparity here, because you see that the white population is 36% responsive for the number of deaths, but they're also probably because they're the ones that have been most effective in nursing homes, which are a particularly vulnerable population. So the answer to that question is pretty tough. We're certainly not seeing very huge disparities like in other states. We know that illness goes where access to healthcare is lower and where poverty is higher. And so our population is certainly vulnerable because our access to healthcare is lower than other demographic groups, and also because of socioeconomic status. COVID, the highest risk factors for mortality aside from age are heart disease and diabetes, and our population is disproportionately represented in those areas, especially in diabetes as you age. So for your safety, we've been doing a couple of things. We've been planning the visits, calling patients ahead of time to make sure that if you have symptoms, you don't show up without us expecting you, and we can redirect you to another clinic. We have smart medical appointments, meaning that we're using technology. So we've been leveraging telephone visits for our patients. We've been leveraging e-prescribe, so you don't have to come in to get a paper prescription. We can send that to your pharmacy, and we can mail you your prescriptions also. And we have secured access to the hospital. So we have been limiting access to the hospital. Many areas, many hospitals have done this to ensure that there's not a lot of traffic, decrease the number of people that could possibly be exposed in waiting areas, and decrease our staff that could be exposed as well. So right now, the hospital does not allow visitors unless you're a pediatric patient, unless you have a terminal illness, or unless you're a laboring woman, and you're allowed one visitor during your visit. This is a busy slide, but just to let you know all the things that we're doing in the community. So we have developed a leverage technology, and that map of zip codes, we are able to overlay the addresses and the location of positive patients with our patients. And so we can tell if somebody lives in the proximity of an area that has a high concentration of COVID patients. We have nurses call those people to try to review with them symptoms, give them some information about prevention. And if it seems like they have symptoms, we bring them in for testing. Also, we located the hotspots and the zip codes that are written in there. And starting last week, we did some robocalling to people that lived in that area, and did some text messaging to sort of remind them about, prevention, and actually give them some resources. So we're trying to connect with the areas that are highly involved. And also we added walk-in testing in all of our community clinics, which are concentrated in the areas that we have our patients, which are mainly in the South and East Dallas area, and in the Garland area. Just a couple of, as a matter of closing, just a little bit of reminder. So the things that I need for people to know about safety, these are the high fives. Hand hygiene is very important. And so we're not in the clear yet, and people should be meticulous about hand washing. Soap and water is fine. You don't need to buy gel. High touch surfaces, especially if you're in a place of business. Very clean areas, cleaning door handles, preventing people from having to multiple touch some areas are very important. Screening of contacts. So if you're sick, you have a fever or you're sick, we're trying to tell people don't come to work if you're an employee, and if you're a patient, let us know so that we can anticipate you. Symptoms and temperature, like having a fever, could happen, but you could be infectious a few days before then. And so it's really important to be very aware and have social distancing. And that's why social distancing is very important. We are saying 6 feet because of prior experience with other viruses. The science is not still out yet. If you're exercising, you may need a little bit more time, more distance, because you're aerosolizing and breathing and talking. And then physical barriers like you have seen in terms of plexiglass or distancing between areas of entry are important. The masking is very important. If worn correctly, meaning covering your mouth and your nose, it can prevent 90% of your droplets. And so the mask is, it means that Dr. De La Cruz is protecting you from him, but you protect me from you. So the people that are not wearing masks are not thinking that they could be the ones that have COVID and they could be giving it to other people. So in a sense, I thank the people that are wearing masks, and in the hospital, I remind people the mask goes over your nose and not hanging down here, because sometimes it gets a little hot and people push it down. If you need a cloth mask, a double layer cloth mask should work. And this is the last part, which is really important, culture. understanding that we're in this together, you know, and that we should have some social responsibility to take care of each other. We should be taking care of people that are older and helping our elderly who are especially at high risk. I like this phrase, we're in the same storm, but not the same boat. So we all have different realities, but the reality is similar because COVID can affect anyone. And so the mortality has been higher in men, but COVID can affect anyone. It can affect children, or children can become carriers. So it's very important that we sort of think beyond just us. And then lastly, one very important thing is seeking care for medical emergencies. We are worried, hospital systems are worried that people are sick and staying home. We have started seeing some advanced illnesses of people that have delayed their care. People are scared, you know, to come to hospitals, but we can assure you that the hospitals are prepared, and our COVID patients are in different areas in the hospital, and our emergency departments have protocols that try to prevent, people being close together and try to protect the people that are waiting. The waiting rooms in the emergency departments have been redesigned. They're not full of people like they were before, and the flows have been improved as well.
So for the people that have been told, you know, elective surgeries have been postponed, if you have diabetes, cancer, you know, any other kind of other illnesses, can those people now access Parkland like they used to do before, sort of that focus on the COVID-19 patients?
Yeah, so in terms of procedures, we started last week to bring back patients that had urgent, time-sensitive surgeries and procedures. So anything that was emergent was proceeding. So we were still, you know, the operating room was open, our procedure areas were open, but there's some cases that could have been delayed safely. And after we delayed them for, you know, 6 weeks, it's time to bring them back. So last week we started that process. We still have community that is scared, and we have people that don't want to come back, you know, yet. But you know, if your cardiologist says that that you need to have a heart cath for some testing for some blockages, that is not an emergency unless you're having a heart attack, but it's urgent, and we're ready for you. And we're calling people and bringing them back right now. All hospitals have been doing that. We are going to continue with telehealth. We're going to continue to do telephone and video visits. The patients really enjoyed them. Their show rate was very high. And we've done some satisfaction surveys that show very high acceptance rate for those. But you know, you can't do telehealth for a long time in a condition. You have to still bring the patient and examine them. So we're in the process of starting to open some capacity in our clinics. By June 15th, we're going to be running at about 50% capacity. And the balance is going to be still on telemedicine and telehealth. And we will continue to monitor the number of patients that are in the hospital and how sort of the system is handling more people, you know, in the hospital as we continue to open up gradually.
What is the have y'all at this point now? We're 2 months into the pandemic in Dallas County. What is the fatality rate, I guess is what it would be called, for those that actually get it? There's still a lot of fear that if you get COVID-19, there's sort of like a death sentence. While we know that the numbers we're hearing, that's anywhere between 2 to 4% of a fatality rate for those who do get it, and geared toward the upper age group, like over 70. Have you found that to be true in Dallas County, or what are we seeing there?
Yeah, that is correct. In Dallas County, it has been around the 3%, you know, rate. Different hospitals have different patient populations and different acuity. We are lower. Our mortality rate is less than 2%. If you look at all of the patients that we have diagnosed, and I think we may have a little younger population, but we also have leveraged, you know, a really good system. Like we have all of our patients together with a critical care team, a hospital medicine team that are working jointly for the betterment of the health of the patients. And we also have accessibility to some of the investigational therapies. We had that all along for the benefit of our patients, and we think that that may have been helpful also. We've been really aggressive in trying to find therapeutic interventions for them. The patients do get very ill. The patients that are on a ventilator are very, very sick, and the mortality if you get too sick and you need a ventilator, it means that your body's not has a cascade of complications, and that mortality is a lot higher than if you're sort of recovering. Most people do recover, but for influenza, for example, the mortality is less than 1%, and for this it's a lot higher. So the issue is that when you have thousands of people infected, you'll have people ill at the same time that were not here just a few months ago. These cases didn't exist, and so that's why hospitals were planning to to take care of them, and potentially they can get overwhelmed. If you add 100 patients to a hospital that is not prepared, and then you disrupt the balance.
Finally, a lot of parents have called concerned that some of the school districts are saying they are planning to start school in the fall, in August, September, and return students back to classroom. What do you believe is a risk right now for, let's say, elementary school students to return to the classroom in August based on the numbers you're seeing and the demographics of the people that have been sick with the COVID-19 and recovered or have not?
It's hard to say because we still have the summer ahead, and my job is to worry. So I worry about when you ease social distancing and people start behaving the same way they behaved before, that we will have a rebound. I do believe that we will have COVID for some time, and the main models out there. This is a very complicated country. There's a lot of movement, and it's going to be very hard to suppress it completely. Some models out there have COVID still in the U.S. for up to 18 to 24 months, smoldering at a low rate. So hospitals will need to be prepared to identify any patient that is at risk of COVID, increase testing vastly in the hospital, so that way we prevent local spread. For children, I've had that question as well. The data that I have right now shows that about 1.5% of people that are asymptomatic in Dallas are testing positive for COVID. So it's low, but it's still there. And it's consistent. All hospital systems are seeing that, less than 1% or 1.5%. As time goes by, we'll be able to track that. And if that is sustained and the level of asymptomatic positive is very low, then going back to school should be fine if the personnel in the school stays at home if they're sick, if children stay at home if they're sick, and if they don't have that, and if they have some measures in which they limit class sizes, etc. But it's hard to say, and the summer still hasn't happened yet. It's a common concern, and it's very complicated because if you're not at work, if your child is not at school, then you can't work, or you have to provide care for them too. So it's very difficult for families.
Okay. All right, Doctor, that's all the questions we have for this webinar. Anything you would like to add to the audience that's going to be listening here in North Texas?
Yeah, I'd like to thank everybody. So this slide shows a poster that was made by a school, Gracias por su gran trabajo, which is meant, and it's posted inside the hospital to thank the healthcare providers that are here providing care. We have received more than 50,000 meals for our staff, which has been distributed by a system of volunteers throughout the hospital system. And we were really grateful for the support of the community and all the goodwill that the community has given towards us. These are the emails that you can access if anybody has questions about bringing any donations to the hospital or the staff. I can assure you that the frontline staff is receiving all these grateful messages, and we're really happy about it, and we really thank you for it.
Well, Dr. De La Cruz, on behalf of LULAC and on the community, we thank you for all the information you've given us today. I think it's important that we get that out to the community. We'll be doing another webinar in Spanish at a future date. And, we really appreciate and support the frontline troops. I know that it must be difficult being there when people are coming in. And I know there's been a lot of doctors and nurses that have gotten sick treating some of these COVID-19 cases. And so we appreciate everything you do for the community under these kind of tough conditions in a pandemic. Gracias.
Thank you so much. Thank you.
Thank you. Bye.